health emergencies that are happening on the continent and what Africa CDC is doing. Colleagues, as usual, we know after the director's briefing, we're going to move into our question and answer section. That way you are able to interact with the director, sending your question, and then we forward to him for adequate response. To do that, as usual, the channels, we have three. One is the Zoom channel, two main methods there. You use the Q&A, write in your questions, of course, with the name and of course, your institution that you represent. And then the next one would be on live. You can use the raise your hand icon at the bottom of your Zoom screen, and then we will recognize you and let you come in live directly to us. The third medium would be our usual WhatsApp group for media, the WhatsApp number +251 94550 2310. Let me read that again, +251 94550 2310. Send out your questions, and then we can forward that to the director doing our question and answer section of this briefing. So without much ado, let me turn you over to our host for today. Dr. Ahmed, is over to you. Thank you.
Thank you, Nick. And good morning, good afternoon, good evening, wherever you're joining us from. Welcome to the second briefing of 2023 from the Secretariat of the Africa CDC here in Addis Ababa. We've begun the year in a double-edged way. We have very good news, but also we have challenges that are coming in right at the beginning of the year. The good news, let me start with that, is the Ebola outbreak in Uganda was declared closed yesterday. We counted until the midnight of January the 10th, and yesterday, January the 11th, 2023, that particular outbreak of the Sudan type has been declared closed. So we began the year on a very good note by declaring that particular outbreak closed. That outbreak, as was discussed yesterday during the closure event, has several characteristics that I would like for us to take away and appreciate the changes that are happening on the continent of Africa. One is that in under 70 days, we brought an Ebola outbreak under control. In fact, it was exactly 69 days from the day that the first case was confirmed until the last case was discharged. In this way, we are seeing a very good trend where our systems on the continent are responding effectively to an outbreak that has the capacity to disrupt socioeconomic activities like Ebola, particularly the Sudan type, where we don't have any rapid tests and we don't have any vaccine yet. So within 69 days, in under 70 days, we brought that under control. Very, very good characteristic for that. Second is that we used public health measures in a very targeted fashion, including restriction of movements in a targeted way, lockdowns in specific areas, curfews in specific areas. And members of the public, in the beginning, it was a challenge, but as soon as they understood why this was being done, they came on board and have been the biggest asset to the speed with which this particular outbreak has been brought under control. So using public health measures in a targeted way, as well as ensuring that members of the public are part and parcel of the response, has given us very good results. The third characteristic that this outbreak has had is the level of coordination that the government of Uganda has had amongst the partners. There have been many partners, over 50 of them, that have been supporting the outbreak response. And the coordination has been very, very efficient. And we must commend the government of Uganda, particularly the health minister there, for being a very good coordinator of the different partners that were on the ground. That effective coordination resulted in synergy and therefore very early control of this particular outbreak. So we began the year on a very good note. When we look at the public health events across the continent, we have a few dozens that we are monitoring in different countries, and we have 7 that are of concern, and therefore we are giving these 7 very detailed attention, and we have 4 that we are actually actively responding to. We grade responses, and by grading the responses, we know what kind of effort we then put in when it comes to response. The 7 of concern that we are dealing with now is, one is Ebola, the one that has come to an end. The outbreak has come to an end. Second is COVID. Third is the multi-country Mpox outbreak. Fourth is the multi-country cholera outbreak. Fifth is multi-country Lassa fever outbreak. Sixth is yellow fever, again multi-country. And 7th is the West Nile virus outbreak in Libya. This is still amongst animals, but we are watching carefully so that it does not get into the human population, and neither does it spread widely in the animal population. So these 7 are of concern, but the 4 that we are watching, and I'll share some details today, are COVID, Ebola virus outbreak, Mpox, and cholera. And I'll give a little bit of detail with Malawi, where really our focus currently is. So for the Sudan Ebola virus disease outbreak, I've already given a summary of that, and we are very happy that this has come to an end. Let me add that we continue for the next 90 days to work in the communities. We have enhanced surveillance mechanisms, particularly in the epicenter areas, but generally across Uganda. We are also still working with the neighboring countries to ensure that cross-border activities remain very active. And secondly, we are still strengthening laboratory capacity, particularly in the areas where the health system had been weakened. Thirdly, we are still within the community. We have our village health teams working within the community to ensure that the understanding that we had during the crisis continues and strengthens the way in which we respond to any other outbreak that may be able to come. Fourthly, the preparations for the clinical trials continue. And although the protocols will be adjusted because there are no more cases, but that still continues because we want an effective virus against, an effective vaccine against this particular Sudan type of the Ebola virus. And finally, coordination amongst the partners is also continuing to ensure that we infuse resilience into the areas that we've been responding in, and in general across the whole health system in Uganda. You will also recall that when in October there was an emergency meeting of health ministers from Uganda and her neighbors, we established the Africa Ebola virus task force. That is still in place, gathering information, sharing knowledge, and establishing mechanisms for coordination, not just within Eastern Africa, but also across the continent, so that we are better prepared for Ebola or any other outbreak of this nature that may be able to come into the future. So we are still very much within Ebola response, although we have declared the outbreak over. To COVID. As of the 12th of January, today we have documented as follows: 12.2 million cases, which is about 2% of the total cases reported globally. 256,000 deaths, which is about 4.1% of the cases reported globally. giving us a case fatality rate here on the continent of 2.1%. We are losing 2 out of every 100 cases that have been reported on the continent of Africa, still much higher than we would have liked. The good news is that since the last briefing, no more new waves have been reported on the continent of Africa. The numbers still remain manageable. And this, again, is a good piece of news from the continent. You will have heard of reports of the sublineage, but particularly XBB 1.5. This has now been documented here on the continent of Africa, in Botswana and South Africa. We are currently monitoring that situation very closely. We continue to sequence samples from across the continent to monitor which subvariants or which variants may be able to come, which lineages, sublineages may be able to be detected. And at the moment, we do not have any reason of concern regarding the identification of XBB 1.5 in Botswana and South Africa. And the reason for that is that Omicron already peaked, particularly in the Southern Africa region. And the sublineages we do not expect will give a different profile of transmission because of the relatively high rate of both natural and vaccine-induced immunity that we have on the continent. But we continue to monitor that very, very closely. When we look at trends, when we compare week 1 of 2023, that is 2nd to 8th of January, and we compare that with the week 52 of 2022, we see 4,792 new cases have been reported during this week. And this is a 40% increase in the number of cases when we compare to the increase in the number of cases. We are also monitoring very closely, as it is quite linked to the holiday season, and we want to see if there is any significant effect that the holiday season may have had. When we look at the number of new deaths, we have documented 21 new deaths during week 1, epidemiological week 1 of 2023. And this is a 133% increase when we compare to the previous week. Again, we are monitoring this very closely and looking at the data from across the continent carefully so that we can be able to respond appropriately if at all there is need. We are also closely following up across the globe the spikes in numbers in certain parts of the world and how those may be able to affect our response here on the continent. At the moment, we do not see any need for travel restrictions. They will not be effective at this stage of the pandemic, and we are encouraging our member states to continue monitoring through targeted testing and, of course, vaccination. But for travel, we do not recommend any travel restrictions. When we look at the 4-week trend, and that is the last 3 weeks of 2023 compared up to the first week of 2023, we see that there has been an overall average increase by 6% in the number of new cases across the continent. So the trend we are seeing in the weekly trend analysis and the trend we are seeing in the 4-week trend analysis tells us that we need to be more watchful, monitoring where these numbers are increasing. When you look at the number of deaths over the 4-week period, we are also seeing a 4% increase. And this, again, tells us that although there are changes in the numbers, it is still not yet at a scale that will be different from what we've been doing for the last almost 3 months. These observations in the number of new cases and also in the number of deaths reported over the last 4 weeks has resulted in our advice and recommendation to our member states to continue with the vaccination campaign against COVID-19 We want to increase coverage and immunity so that we have a much better protection amongst members of the public. Secondly, we are encouraging increased testing so that the true burden of disease can be able to be known. We are also encouraging genomic surveillance so that we can be able to monitor any variants, subvariants, sublineages that may be able to come. Surveillance needs to start not just at the community level, but also at the health facility level, so that anybody presenting with any influenza-like illness can be given an opportunity to check if at all it will be COVID-related. We are also encouraging our member states to report to Africa CDC in a timely manner that will allow us to be able to know the number of new cases, the number of new deaths, any recoveries, vaccination status, tests that are being done, and any support that may be required to our health workers who are in the front line. So this is the advice that we're giving our member states at this stage. Vaccination continues on the continent. And to date, we have received 1.076 billion COVID-19 vaccines doses on the continent, and we have administered just over 882 million, which is about 82% of the total supply that we have received. Coverage, it continues to improve. When we look at our target population of 12 years and above, we have now done about 43% of this target population, meaning about 400 million people have been fully vaccinated on the continent. This means that almost 4 million additional people have been vaccinated since the last briefing that we had. The scale is good, and we are encouraging our member states to pick up as we get into the new year. Boosters are also being administered, and to date we have 3.26% coverage for booster doses, which is about 44 million people having been boosted with a third or a fourth dose in at least of the 42 member states who are reporting the booster numbers that they are giving. When we look at our target population of 12 years and above, 14 member states have now reached the 70% target for this eligible population, and we are working with others to be able to reach and surpass this particular target. It is very important that we reach these targets because we don't want any variant, subvariant, or sublineage to disrupt the good work that has already been done on the continent. So we recommend not just getting the vaccine, but also getting a booster for those who are eligible. Specifically for our SLL program, the Saving Lives and Livelihoods initiative, we have so far 18 African member states who have begun implementation. And these 18 continue to expand the reach of vaccination within the population. And in fact, about 182,000 vaccine doses have been administered this last week, giving us a total of about 10.8 million doses administered by the program from the beginning of the campaign. We continue to bring on board more countries into the Saving Lives and Livelihoods program, and we are looking forward to even more doses being administered through this very, very innovative program that we started since last year. The next is the next public health event of concern that we are actively responding to is a multi-country Mpox outbreak. As of today, when you look at this week and the last briefing that we had, 5 new confirmed cases have been reported from 2 countries and no new deaths. 5 new confirmed cases and no new deaths. And the 5 confirmed cases are from Liberia and Nigeria. Cumulatively, from the beginning of this current outbreak at the beginning of last year, we have documented 1,267 cases and 226 deaths as a result of Mpox from 13 of our Africa Union member states. And this case fatality rate translates into losing 1 in every 5 confirmed cases, which is not a very good situation. And we are trying to ensure that we control that as best as possible. 3 countries still remain the ones that are accounting for the vast majority of the cases of Mpox, 94%, and that is DRC, Ghana, and Nigeria. But in total, 13 of our member states have been affected by Mpox during this current outbreak. As Africa CDC, we have been providing key support to all the member states, particularly the ones that are affected in a big way. Apart from risk communication and community engagement, we are providing laboratory support, including relevant test kits. We are providing capacity building for all health workers involved in the Mpox response. And we have also secured vaccines that we're in the process of ensuring regulatory approvals before we can be able to deploy them in the high-risk countries amongst the high-risk populations. Finally, for the public health events of concern that we are actively responding to is the multi-country cholera outbreak. Since the last briefing, 4,032 new cases have been documented, and 393 new deaths have also been documented as a result of cholera from 4 countries, and that is Burundi, Cameroon, Malawi, and Mozambique. 71% of these new cases and 88% of the new deaths are reported from Malawi, meaning it is really the epicenter for the numbers that we are reporting, although many other countries are also reporting cases. Now, when we look from the beginning of this current outbreak, we have reported over 102,000 cases and over 2,000 deaths from 14 of our Africa Union member states. This case fatality rate of means that we are losing 2 out of every 10 cholera cases, and this is a situation that we really need to change quite rapidly. When we look at the totality of cases, Cameroon, DRC, Malawi, Nigeria, and Somalia account for over 90% of the cases, although many other countries are reporting smaller numbers of cholera. It is the season because there's rain and flooding in many parts of the continent, and so we are supporting these member states to ensure that keep the numbers low as we establish a better public health environment in terms of sanitation, water, etc. At country level. Now, we want to focus a little on Malawi. Since the declaration of a public health emergency due to cholera by His Excellency the President of Malawi on the 5th of December, we have been providing support and working with the government of Malawi to address the most critical needs. Most of the districts in the country have been reporting cases, and this means that the response is therefore country-wide. You will recall that this started in the context of Tropical Storm Ana and Cyclone Gombe, and has continued to spread amongst the population. Access to basic water and basic sanitation is key to our response, even though we continue to treat those who have been affected. To date, 14 member states on the continent are reporting cholera at different levels. But when you look at Malawi, the numbers are high, and a very large part of the country is also affected. We as Africa CDC are deploying an emergency team starting from today to provide the much needed coordination and expert support that Malawi requires. We want to be able to monitor the environmental sources and consequences. We want to ensure that all water sources that are being utilized in the communities have been quality assessment has been done. We want a stronger surveillance system in place so that we can pick out the hotspots, address those quickly as we continue to engage with the community in an effective way. We want to ensure we are also supporting community health workers, being there to provide information and show the communities how we can be able to prevent this rapidly. And we are also working with the government to ensure that water, hygiene, and sanitation commodities are in place wherever it is that they may be needed. So the situation in Malawi is special when it comes to cholera, and Africa CDC have deployed on the request of the government there so that we can support their response activities. Finally is some few reflections as we go into the new year. No specific announcements for today, but there's some reflections that we have is that Africa, when we look at the experiences that we've had over the last, especially 1 year, since the beginning of 2022, we have continued to share the successes and what we did to make it successful. And we are very glad to see that other parts of the world, countries from other parts of the world, institutions from other parts of the world are actually reaching out to learn from our challenges so that they too can be able to be better prepared going into the future. For 2023, I would like to add that the continent, our member states, Africa CDC, African Union, our regional economic blocs, we are preparing for the negotiations for the pandemics treaty. We are also ensuring that as we go through the process of review of the IHR 2005, the African voice, the African experience, the African positions have been well captured in both these very important global level documents. So thank you for your attention for today. And Nick, back to you.
Thank you, Director. Very comprehensive briefing there. Speaking on several different outbreaks happening on the continent, and of course, ending with the significance of African voices being heard in those different global negotiations. So the briefing today, colleagues, you heard covered starting with the Ebola situation that's subsided in Uganda, moving on to COVID, then the director ended with, of course, the cholera, pointing out a special focus on Malawi to be the next focus of Africa CDC in terms of outbreak response, even though we are still supporting member states in other areas. So colleagues, once again, let me repeat our mood for sending in our questions as we are now transitioning to the question and answer section of this briefing. As usual, we will use the raise hand icon on the Zoom screen, just at the bottom. You will see the raise hand icon, just use that. And you can come to us live. As a matter of fact, we already have 2 of our colleagues who have raised their hands. That is Paul Adepuju and another colleague. We're going to come to you shortly. And then you can also make use of the question and answer section of the Zoom screen as well. And lastly, you can use our usual WhatsApp number, +251 94 550 2310. As I navigate through the different meets here, I see that our colleague Sarah Jevin has also come through on the WhatsApp. So colleagues, we're going to just jump quickly into the question and answer section. Let's do justice to the colleagues who have raised their hand earlier. And we are going to start with our colleague, Paul Adepuju. So the colleague on the background, kindly allow Paul to come through with his question. Paul, it's over to you.
Yes, thank you very much, and Happy New Year to the entire Africa CDC team. So I have a couple of questions for Dr. Ahmed, and the first one started from the conference, and where you announced the centers focus to prioritize and mainstay participation of youth. So from an infectious disease control perspective, what do you think, and how do you think bringing focus on youth as strategy for infectious disease, how do you think that is going to play out? And what do you think would be a top priority to focus on, such that the youth, African youth, play more active roles in infectious disease control, and strategies that put them into consideration actually deployed? Then yesterday, WHO DG announced in a briefing that there has been a significant drop globally in the number of sequencing. He said from the peak of Omicron that there has been up to 90% reduction in sequencing. I'd like to know what is happening in Africa, whether we are seeing a similar trend, and what Africa CDC's initiative to address this issue is the strategy is about. And a third question for now, if I can quickly chip that in, has to do with the Uganda Ebola outbreak that officially ended yesterday. In a statement, the Minister for Health said that I still no clear-cut information on the source of the outbreak. And considering the fact that you said in this briefing that other parts of the world are coming to learn from Africa regarding responding to outbreaks, what do you think is still lacking, and why does this we still seem to struggle with being able to identify the primary source of an infectious outbreak like this? Thank you very much.
Yeah.
Thank you, Paul. So Director, we'll just go straihtly to you.
Yes, no, thank you. Thank you very much, Nick. And thanks, Paul, for those questions. Let me start with the last one. I think it's a lot more complex. Indeed, yes, we still do not know the exact source of this particular outbreak of the Sudan type of Ebola virus in Uganda. And it takes very careful anthropological studies to be able to trace back to where it may have started. You will also recall that this will have been very difficult to do during the height of the outbreak, because we were very concerned at that time with reducing exposure from those who are infected to those who are not infected. Our focus was very different. Right now, we are supporting the government of Uganda to do that particular study, to trace back where could it have come from, and that will help us to prepare going into the future. The reason why it is a challenge is because there was a gap in identifying that an outbreak was actually in place. It took at the very least 10 days before the system picked that up in a comprehensive way. So we lost a little bit of time, and that loss of time, some information was also lost. Now we have to go back and carefully look at the situation there. So it is a challenge, but it is not unique. Whenever you have an outbreak of this nature that is not clear where it has come from, you need to be very careful how you trace it back. COVID is still with us without a very clear-cut source and of the infection as well. But as other countries come and other regions come to the continent to try and learn, these are some of the things that we are sharing. The need to have that first case be identified very quickly, and then we can trace back more easily where the source actually was. And this is a work in progress. We'll be sharing it as information comes from the study, anthropological study that we are doing. Second is the issue of youth. This continent is 60% plus youth. Everything and anything you do, if it does not specifically target the youth, then it cannot be successful. And we as Africa CDC, because we go to the community where we are responding, we can see the huge number of youth who are there, whether it is in urban centers, whether it is in the rural side. Youth numbers are huge. And so we are convinced that engaging the youth in a special way is going to make a difference. But we want to do that in a very systematic way. And that's why the youth advisory team is going to be important, because they'll be bringing in very new thinking how we can be able to engage with the youth. But where infectious diseases are concerned, the youth are in the community. Outbreaks start and end at the community level. If a community's majority population are youth, if you target them, then your messaging is going to be reaching the majority of the population. And eventually the whole community is going to be very well informed. So going forward, the way we see this playing out is youth are engaged, especially from a targeted perspective, where if you have messaging, you make sure the youth are well targeted. If you have a campaign, if you have an initiative or a program, the youth have been well targeted. The results, I strongly believe, are going to make a difference in public health here on the continent. Finally is about sequencing. Dr. Tedros is absolutely right. There's been a global drop in the number of samples that are being sequenced. And this is expected because we sequence to look for something. When the outbreak, the pandemic is not acute, the numbers are dropping, then there are less samples being collected, and therefore there will be less samples being sequenced, because sequencing, you don't sequence every sample. There is a proportion and there's a way, there's a protocol of picking out those proportions from amongst all the samples that have been collected in a particular locality. So when the overall testing is low, then the overall sequencing will also be lower. And there has been a drop. We are working with our member states to ensure that that drop is not significant, and we keep it at a level that is giving us information that is good, and therefore information that we can be able to use for planning, for response, and for resilience. So this is work in progress, and it is a challenge that we are facing very, very squarely. Nick?
Thank you, Director. Very comprehensive responses provided to Paul's questions. I know Paul will want to come back for the second time, but Paul, we plead with you to bear patient. Let's give other colleagues the opportunity. The next colleague who had the hand raised is our Collector Wanjoyi, our colleague who is always without. Collector, next, over to you for your question. Thank you.
Thank you, Nick. Good afternoon, Doctor. I would like to ask, still on the issue of Ebola, Uganda being declared quote unquote Ebola free is good news. But if we look broadly, we've also had some the Ebola virus cases being a bit stubborn in the DRC. What would you term as the issues that have made it be possible for elimination of the virus or of cases? Where would we term as the success aspects as far as the continent is concerned in terms of eliminating or putting Ebola under control? Then secondly, on the same issue, what would be the specific call from the Africa CDC to the communities around the continent in terms of ensuring that we don't fall back to the same scourge of Ebola? I mean, not only Uganda, but also it can happen to any other country. So what would be the specific message to the individual, to citizens around the continent? What should we do so that we keep ourselves safe? Thank you.
Thank you, Colette. The reason, well, there are several reasons, but I'll pick two key reasons why in Uganda we've managed to bring this particular outbreak under control faster. The first is access to the public. When you can be able to access the affected community almost 100%, then you can be able to engage them directly, regularly, consistently, and monitor what that engagement, the results it's giving you. In the DRC, it has been a bit of a challenge, particularly in the area, the corridor where there's been a conflict continuing. Part of the reason why there's a bit of stubbornness in that particular part of Africa. In Uganda, that access was complete. So this is one very important thing, access to the public. Second is coordination of effort. There's always, whenever there is a crisis, there's always a lot of possible help. There's always a lot of actual help that comes. If it is not coordinated, it does not give you quick results. In Uganda, the coordination was from the get-go. Right from day one, the Minister of Health was in charge of the process, and she coordinated it all the way until the end of the outbreak. Very, very important that we have coordination happening at country level. So these two I will pick out. There are many others I will pick out as key in making sure that we can be able to bring any outbreak quickly under control. Now, in terms of calls to communities, outbreaks start and end at the community. If the community is at the center of identification of an outbreak, you get to know about it quickly. If the community cannot identify that there is an outbreak, or when they do, they keep it to themselves, then it spreads to many more people. You always want to catch that index case so that you can be able to arrest that outbreak when it is still 1 or 2 people. You don't want to wait until it has gone through to tens or hundreds of individuals. So the specific calls that I will have to communities is the importance and urgency of sharing information when there is something new in the community. If someone is running up a fever that has not really been seen before, it is very important that that information reaches the authorities quickly. When the cases start to rise and the government wants to respond, or when the government has known there is an outbreak and the government wants to respond, my call to the communities is cooperate with government. Because when we do that, we are able to bring the outbreak under a fast control. And finally, is my third call to the communities is the importance of working with the agencies that have been given the responsibility to respond, not just to listen to what the government is asking you to do, but also to actually work with those agencies who have come to the ground. So if there is need for respectful and burial, if there is need for some level of quarantine or restrictions in movement, we work with those agencies. We don't just listen, but we also work with them. So these 3 things will be my big calls to the communities. Something is new, let us know about it quickly. When the government has passed information, let's respect that information, understand it. And when the agencies have come to the ground to be able to help in the response, let's work with them. In this way, we are going to bring these outbreaks under control faster and avoid them becoming large problems across the continent. Thank you.
Thank you, Director. Report it, listen, and work when there's help for you. Isaac, you've raised your hand, but let's do justice to somebody's microphone is not muted. Okay, thank you. So Isaac, you've raised your hand, but let's do justice to the other colleagues who are coming in on our other platforms. I see there are questions in the Q&A section, but before I go to the Q&A, let me take our colleague Sarah Jevons from DevEx. Let's take her question. Sarah wants to know, Director, what do you expect to be the continent's position on the global pandemic treaty? That is what Sarah is asking for today's section.
Thanks, Sarah. The specific positions will come when the negotiations begin, but we are going to be driven very broadly by Africa's new public health order. Any treaty that is negotiated at the very minimum must have an enforcement mechanism. If there is no enforcement, then it just becomes an agreement between friends. And that will not lend itself the power to respond quickly and effectively as we've required it to be done during, for example, COVID and other outbreaks. So this is one very important thing, that an enforcement mechanism is required. The second is a treaty must be resourced when it comes to implementation. And aspects of implementing the treaty, domesticating it, and eventually putting programs in place at country level that respond to the articles of the treaty is critical. If you have an agreement that is not being translated into action, it becomes a very expensive piece of paper. But if it is translated into action, it becomes an important tool at country, regional, and global level. Third is the experiences that we have on the continent during the pandemic globally needs to come to bear. It must be part of the treaty. How do you have access to diagnostics? How do you have access to the whole range of medical and non-pharmaceutical countermeasures? How do you have access to vaccines? How do you have access to samples of a particular novel new pathogen that may bring an outbreak? How do you share that access based on public good? So these are some elements that we have learned during the various outbreaks that we have undergone that we would really like to see to be part of that particular treaty. And finally, and very importantly, is every outbreak begins at the community and ends at the community. Africa is a community, and we believe strongly that regionalizing preparedness, response, and resilience is the new thing that we need in the health security agenda, in the health security space. Many more positions will come up, Sarah, and we'll be sharing that in the next months as negotiations carry through. But for us, these are some of the areas that are going to be very, very important to not only be discussed, but to be solidly captured in the treaty in a way that is implementable, in a way that is enforceable.
Very well captured there, Director. All just summarizing the new public health order for Africa. So let me go now for our questions into the Q&A section on Zoom. I think I've got, so there's several of them here. I see Isaac, you've already rating here. Leocadia has rating here. And the first person who wrote here is Matthew Motiria. His is not a question, just to commend Africa CDC and member states for the effectively embracing the coordination and collaboration in handling public health issues in Africa. He says kudos. Then Isaac writes, so Isaac, if we are asking your question from here, then again, we're not going to give you a chance for speaking. So let's ask your question from here. So Isaac writes, I'm Isaac Imoto, Africa CDC Chief Bingwa in the coastal region from Mombasa, Kenya. So Isaac, this section, this forum is for journalists. So we apologize. We can put forth your questions because this session is for journalists to ask questions. So we will move forward to other colleagues who are media people. Leocadia writes, the majority of cholera prevention strategies, including immunizing populations with oral cholera vaccines, oral cholera vaccines as well as providing clean water and good sanitation to those who do not yet have access to these necessities. How is the Africa CDC working to integrate SDG 6, clean water and sanitation, and Goal 3, good health and well-being, specifically in relation to furthering the agenda of the new public health order? That's what Leocadia Modma is asking.
Thank you, Leocadia. A very broad question. I'll divide it into three. One is that Africa CDC, we approach all our preparedness, planning and response to outbreaks holistically. We will look at the virus, we will look at the individual having the virus, we look at their environment, and we look at the infrastructure that supports the well-being of that particular community. We do it holistically. The portions that we are responsible for, we deliver, and the portions that are the responsibility of other agencies, we work with them to be able to deliver. On cholera, for example, two very important parts is safe water and safe sanitation. If you don't have those two in place, you cannot be able to break the back of a cholera outbreak. And so we are working with the relevant agencies in the countries concerned to ensure that safe sanitation and safe water is there first. And then we begin the whole process of identifying those who've been affected, providing them with the treatment they need, and of course, the knowledge how they can be able to protect themselves. But our approach as Africa CDC is holistic. Second is the resources that are required for response. We also approach this from not just that this is cholera or this is water and sanitation. We approach it from the aspect of what is the public health effect that we want to achieve. Therefore, we bring to bear all our pillars of work, whether it is capacity building, it is laboratory services, it is community engagement, it is communication, it is policy. We bring those to bear around what is best for that particular affected population. So when we look at the SDGs, we look at them in total. And whichever one that we need to work on at that particular time, then we use that to deliver for that particular community. Our driving visions remain Agenda 2063 and the new public health order. These guide us. And within these two, all the SDGs are covered quite effectively. Thank you.
Thank you, Director. So with just 5 minutes on the clock for our time today, I'm navigating through our different modes of questions here, and I just see our colleague Paul coming back. So we'll just give Paul the last opportunity, and Paul's questions will be for this round, the last question for now, and then as usual, we move to Director for his closing remarks and the 3 normally headline points that come in. So colleagues, let me just remind that this section, the question and answer section on this briefing is normally for the media. If you are opportune to join in and listen, and you are not a part of the media, we request that you just follow the deliberations and please leave the questioning to colleagues from the media. That's why we normally ask the media, when you are asking a question, you identify yourself and tell us which institution you work for. That way we are able to trace your stories and we're able to follow up in subsequent times. So Paul, it's over to you for the last question for today's section.
Thank you very much. And it's just one question that I have for Dr. Ahmed. Last year, I think in October, the Africa CDC held a meeting, conducted a technical consultation with a number of African countries and stakeholders regarding identifying priorities for hepatitis. I know we talk a lot about COVID, Mpox, and other diseases. And that may overshadow other diseases of importance like hepatitis. I'd like to know whether the Africa CDC has identified its priorities regarding hepatitis intervention, and if this is available, what will this be, and what do you see as top priority for Africa regarding hepatitis? Thank you very much.